Thank you for joining us today. My name is Dr. Deborah Richardson, and I am from Oklahoma in the United States, and I will serve as the moderator for this afternoon's symposium, titled From Data to Decisions, Evolving Opportunities in Platinum-Resistant Ovarian Cancer. IGCS would like to thank Corcept for their support of this symposium. Let's get started. We will begin with speaker introductions. Dr. Nicoletta Colombo, please introduce yourself.
Hello, hi. My name is Nicoletta Colombo. I'm a gynecologic oncologist from Milan, from the European Institute of Oncology. And thank you for being here with us today. Thank you.
And Dr. David O'Malley, please introduce yourself.
Good afternoon, everybody. Thank you for joining. I'm David O'Malley from The Ohio State University. For those from the US, you'll understand that joke. We've actually patented the in Columbus, Ohio. So it's been a great meeting. Congratulations to organizers for a wonderful meeting. Thank you.
And Dr. Keta LaRusso, who unfortunately could not join us, did pre-record her segment. She is from Milan. These are our disclosures. The learning objectives for this symposium are to evaluate breakthrough data, to review and contextualize pivotal 2025 Congress data on novel therapies in platinum-resistant ovarian cancer, to interpret clinical impact of new trials, to analyze updated PFS and OS findings, trial design nuances, and their practical implications for personalized treatment planning. Map the evolving therapeutic landscape to position emerging treatments within the current ovarian cancer algorithm, identifying opportunities for sequencing or combination. Oh, there we go. And enhance multidisciplinary application to foster real-world clinical dialogue among oncology professionals to translate data into meaningful care strategies. Shown here is the agenda for the symposium today. To stay on schedule, we will be strictly enforcing the time limitations for our presentations. Now I welcome Dr. Colombo to discuss what's new in platinum-resistant ovarian cancer, highlights from ASCO, ESMO Gyne, and ESMO 2025.
Good afternoon, almost. Okay, so my job today will be to review what's new in patients with platinum-resistant ovarian cancer, and I will focus mainly on what it was presented at ASCO and ESMO GYN and ESMO. So as you know, if we look at what is the standard of care for platinum-resistant recurrent ovarian cancer, what we can find in the guidelines that the first option should be to offer our patients the inclusion in clinical trials. And this is because, as you know, we have very limited options for these patients. And typically, we can offer weekly paclitaxel, PLD, or topotecan, or gemcitabine with bevacizumab. So what is next? What we can do more for our patients? These are some of the strategies that are currently under investigations. And I will start with the antibody-drug conjugates, which, as you know, are really the new frontier in many solid tumors and also in ovarian cancer. Let me see what were the most important results reported in the last year. First of all, as you know, mirvetuximab soravtansine is the first ADC approved in ovarian cancer. And here you see the final overall survival of the MIRASOL study. MIRASOL investigated mirvetuximab compared to standard of care in patients with platinum-resistant recurrent ovarian cancer. And as you can see here, the final analysis, the hazard ratio for overall survival is 0.68 and continue to favor mirvetuximab over investigator choice chemotherapy with a 32% reduction in the risk of death. But of course, this was the first FR-alpha ADC, but there are so many now coming, as you know, so this is not the only one, it's not an oasis in the desert. And if we want to stay in the FR-alpha ADC area, I have to mention the RINA-S. This is again a FR-alpha ADC with a highly hydrophilic linker and a topo-1 inhibitor as a payload. And in this phase 1 dose finding study, you see a high response rate of 50% in patients with platinum-resistant ovarian cancer. And now a phase 3 study is planned comparing this ADC compared to standard of care. The other FR-alpha ADC, which show very promising results, is the AZD5335. This is the Fontana study. There was a phase 1/2A, first in human open label study, which was presented at ESMO 2 weeks ago. Here you see the efficacy of these compounds, and there was a very high efficacy across different doses. You can see from 1.6 to 2.4 milligram per kilogram. And here you see an overall response rate of 53.6%. And the most common adverse events were nausea, fatigue, and neutropenia. And the activity was seen also across different expression of folate receptor alpha. The other FR-alpha ADC is the Lilly compound. Again, you see here the preliminary data with a very high activity regardless the expression of the receptor or the folate receptor alpha receptor. And again, we have a response rate which is in the range of 50% and even higher. Moving to a different target, we have to mention, of course, HER2. This is the Destiny Pan-Tumor 02 study in the cohort of ovarian cancer, 40 patients with ovarian cancer. You see a response rate of 63% in tumors with a 3+ expression of HER2, with a very nice also progression-free survival. The other ADC that I want to mention is the one targeting the CD6, the cadherin-6. And Isabel Recoccar presented the results of a phase 2/3 randomized study of RDXD in patients with platinum-resistant high-grade serous or endometrioid ovarian cancer. So more than 100 patients were randomized to 3 different doses in order to identify the optimal dose for the subsequent phase 3. And again, you see a very, very high level of activity for this ADC with a response rate ranging from 44.4% to 57%. And looking at the toxicity profile of the different doses investigated, at the end, the intermediate dose of 5.6 milligram was chosen for the phase 3, which will very soon start. Very interesting also is another target, NaPi2b, and this is another compound, another ADC, targeting NaPi2b, again with a topo-1 inhibitor payload. Antonio Gonzalez presented at ESMO the results of this phase 1 dose escalation. And look at here, the response rate extremely high across a wide therapeutic range with complete responses even seen. And of course, 93% of responding patients are ongoing. 80% of patients remain on treatment, indicating a very durable benefit. Now, moving away from the ADCs, I want just to mention some other strategies that we are now investigating in platinum-resistant ovarian cancer. One is the cell cycle regulation and DNA repair. So this is a complex slide, but just to simplify, as you know, during the cell cycle, there are checkpoints. Checkpoints are very important because they slow down the cycles in order to repair the DNA damage which may occur. In our high-grade serous ovarian cancer, almost all of these tumors have a p53 mutation, so they they lost these important checkpoints. So the strategy is to block another checkpoint and to cause a mitotic catastrophe and the cell's death. And you can do, and we do have drugs available targeting other checkpoints. For instance, we can inhibit CDK2, and these are the results presented at ASCO with this compound from Incyte. Is a phase 1b in cyclin E1 amplify or overexpress ovarian cancer, showing a 33% response rate. Now, moving to immunotherapy. You know, we thought that immunotherapy was not the good thing to do in ovarian cancer. We had a lot of negative trials, and we thought that the game was over. But in fact, it is not, because, as you know, I presented at ESMO and also here 2 days ago the results of ENGOT OV65, the Keynote B96 study. In this study, we investigated the use of the addition of pembrolizumab versus placebo in combination with weekly paclitaxel with or without bevacizumab in patients with platinum-resistant recurrent ovarian cancer with 1 or 2 prior lines of therapy. We wanted to see if the addition of pembro could improve progression-free survival, which was the primary endpoint, but also we had as a key secondary endpoint overall survival. And here are the results. At interim analysis 1, there was a statistically significant improvement in progression-free survival in the CPS 1 higher population, so when the tumor expressed PD-L1 with a combined positive score of 1 and higher, with a hazard ratio of 0.72, but also in the intention to treat population. So it was not only in the CPS 1 and higher, but also in the intention to treat population, you see an improvement in progression-free survival. But even more important, I think, is the improvement in overall survival. So interim analysis 2 with almost 27 months median follow-up, which is quite long for this population, of course, you see a benefit in overall survival with a hazard ratio of 0.76, a p-value which is statistically significant, and the median overall survival was 18 months in the pembro arm, which is one of the longest ever reported in this population, compared to 14% in a very highly and high-performing control arm. Of course, immunotherapy is not only anti-PD-1, and I think I want just to mention another important possibility for our patients. This drug is a bispecific antibody targeting T cells and cancer cells, and is a very nice strategy in order to deliver immunotherapy in a more efficient way. And again, at ESMO, the results of this randomized phase 2 study of ubamatamab plus or minus cemiplimab in patients with platinum-resistant ovarian cancer was reported. And as you can see, the response rate is not really exciting, but what it is very important to notice is the duration of response. That, for me, in my mind, this is really an ideal drug for maintenance therapy, also because it can be toxic during the first 2 cycles because it can cause cytokine releasing syndrome, but after that it's quite well tolerated. So it could be a good strategy for maintenance therapy. And finally, I want to mention another important strategy which became available very recently, and this is targeting the glucocorticoid receptor. Why? Because this drug, relacorilant, is really a novel and selective glucocorticoid receptor antagonist that restore the sensitivity of cancer to cytotoxic chemotherapy. And in the next presentation, you will understand more in details what is the mechanism of action. I just want to show you the results of the Rosella study, randomized phase 3 study, looking at the combination of nab-paclitaxel with relacorilant compared to nab-paclitaxel in patients with platinum-resistant recurrent ovarian cancer, showing a significant improvement in progression-free survival with the addition of relacorilant, and a very good trend for overall survival improvement. The results are not mature yet for overall survival, but you can see a clear trend showing a benefit for this compound in addition to nab-paclitaxel. So just to conclude, as you see, yes, ADCs are the new frontiers, and so it's very nice to see a lot of ADCs coming, but this is not the only thing that we have available for our patients. So you see much more for platinum-resistant ovarian cancer, and so I hope for them the future will be bright. Thank you.
Thank you, Dr. Colombo. Dr. LaRusso is going to discuss innovative mechanisms and combinations beyond ADCs in 2025.
Good afternoon, and thank you so much for your kind invitation. I'm really sorry for not being there with you. I have to go back to Italy earlier for another commitment. So for several years, we did not have any new drug in the platinum-resistant setting, no drug able to change the outcome of our patient, but you just heard how many new information and drugs we had in the last 2 years. But probably it's important to understand and to going back to the biology of the tumor to elevate the outcome of our patient. For instance, in my opinion, there are 4 to 5 pillars that we have to consider if we want to increase the outcome of our patient. First of all, we have to enhance the understanding of mechanism of resistance, adding new drug to our treatment armamentarium. Cortisol and the glucocorticoid receptor pathway in cancer seems to be very interesting. In normal condition, morning serum cortisol is able to activate the glucocorticoid receptor, and you can imagine what happens in the condition of stress where the level of endogenous cortisol is even higher. Preclinical data suggests that the activation of glucocorticoid receptor pathway reduces the activity of chemotherapy, and in particular in these experiments of corticosteroids. But we know also that the activation of this pathway led to the transcription of some anti-apoptotic genes, and in particular there is the transcription of DAS1 and SGK1, which results in anti-apoptotic effect for our patients. But likely, you already know that now we have the possibility to interfere with this pathway, and relacorilant, a glucocorticoid receptor selective antagonist, has reported to increase sensitivity to chemotherapy in preclinical and early clinical data, and now confirmed also in a randomized phase 3 trial. There is another aspect that can help. For instance, AXL gas-cis pathway is involved in the treatment of resistant tumor because when activated leads to epithelial mesenchymal translation and poor outcome. In a trial in which we combine batiraxept and AXL inhibitor with weekly paclitaxel, we failed to demonstrate a benefit. But when we retrospectively evaluated only the patient with the highest expression of this pathway, a significant increase in progression-free and overall survival was reported, suggesting that there is a signal here. The second pillar we need to rely is ADC. You saw and in these days in the Congress how many new data with ADC we have. Why this is a so important strategy? Because you know that chemotherapy has a really narrow therapeutic window, and in order to increase this window, ADC were created with the idea to selectively target tumor cells. You know perfectly that there are three important components in any ADC: the monoclonal antibody targeting specific target on tumor cell, the cytotoxic payload, but also the linker. And you know that the mechanism of action is really intriguing because as a Trojan horse, the drug linked to the target is internalized and released where it occurs, I mean, in the tumor cell. All the three components play a role. For sure, the target is important or seems to be important to identify most vulnerable cell, but we will see in ongoing clinical trial is the target plays a major role. The linker is important because the linker must be stable in serum and extracellular environment, but should be clearable inside the tumor to release the drug. And also the payload is important. Actually, we have two main groups of payload, the microtubule inhibitor and the DNA damaging agent, and we will see if the mechanism of resistance is related to the target or to the payload in the ongoing trial. But we have not to forget another characteristic of ADC, the bystander effect that represents the possibility for the free drug to move outside the tumor cell and kill also the newborn cell without the target. And finally, don't forget the importance of the drug-to-antibody ratio that expresses the number of molecules of chemotherapy linked to the antibody. The higher is the DAR, the higher is the bystander effect, but potentially higher is the toxicity. And you saw in the last day during this important meeting how many targets in ovarian cancer and gynecological malignancies are expressed and how many drugs are in clinical development in ovarian cancer. The idea to interfere with the cell cycle machinery has always been interesting in gynecological malignancies and ovarian cancer in particular. Unfortunately, until now, this idea failed. Failed the combination of PI3K inhibitor plus olaparib in the platinum-resistant patient in the EPICO trial, failed the combination of WEE1 inhibitor plus or minus olaparib in olaparib-exposed patient, and more recently failed the combination of ATM and ATR kinases inhibitor with PARP inhibitor in ovarian cancer patient. But there is a promising drug in this setting, which is the INCB 123667, which is a selective CDK2 inhibitor that in this preliminary data in a phase 1b study reported 33% overall response rate in platinum-resistant, heavily pretreated ovarian cancer. And the most interesting aspect is that all the responding patients had CCNE1 amplification of cyclin E1 overexpression, suggesting that this is a biomarker. And lastly, probably we have to change our paradigm and reevaluate the biology behind the definition of platinum resistant. In the era of PARP inhibitor, this definition needs to change. Why? Because we have about 30 to 70% of patients with ovarian cancer progressing during PARP inhibitor, and Paula-1 data suggests that this patient has a reduced efficacy when retreated with the platinum, probably because of overlapping mechanism of resistance between PARP and platinum. In particular, the PFS for this patient is around 6 months, and the overall response rate is about 20 to 30%, thus suggesting that this is a population that needs better treatment. And we know that ADC that has been developed initially for platinum-resistant setting works very well also in platinum-sensitive population, and in particular also in PARP-exposed patients. And in my opinion, there is a well-defined place for this drug in this setting. Lastly, we, in such a way, are stuck with PARP inhibitor in the HRD patient, but we have not to forget that the HRD population is an heterogeneous population outside the BRCA. And we have recently discovered that HER2 overexpression in this patient represents a worse prognostic factor. So probably also for this patient, we need a better drug. And this is the Pan-Destiny Tumor 3001 that compare trastuzumab deruxtecan with bevacizumab versus bevacizumab in stage 3-4 ovarian cancer patient, regardless BRCA. And so, in conclusion, we are living a very exciting moment also for this setting of patient that typically has presented a worse prognosis. Now, recently, we have 3 randomized trials that have reported the benefit in terms of overall survival in this population, but the new strategy are arriving, ADC and cell cycle checkpoint inhibitor, in particular, seems very promising. I think that the focus of clinical research in the next year will be to better identify outside the definition of HRD or HRP who are the patients that will need the better treatment. Thank you so much for your attention.
Now I welcome Dr. O'Malley from The Ohio State, where he trained me, to discuss making sense of the curves, how to interpret new PFS and OS curves.
Well, we've seen this data, and I think as we move forward, I wanted to look at it with a little bit different lens here. So we're going to look and really try to see from an efficacy signal standpoint, where are we at when we talk about medians and hazard ratios? Look at some of the crossover influence briefly, and also the tail of the curve effects. And we're going to look at that in context with some of the data we just saw, as well as look at some first-line therapy, because I think it's important considerations as we move forward. I was at the session this morning, and we talk about median progression-free survivals and overall survivals, and that is a snapshot, but it really doesn't tell the story. I'm not sure it even tells the real story most of the time. Remember, it's at 50% of the events. It will underestimate those changes, particularly if we have a long tail or if many of your events occur early, like the first or second disease assessment that we have in platinum-resistant ovarian cancer. And we are often ignoring subset of patients with long-term benefit. The KM curves, I'm a very visual person, so for me, that's how I visualize these trials. But how do we speak about that? So it's not just the medians, but how and where those curves separate. Do we see an early separation like we do in the ADCs, or do we see these delayed response with longer tails like we do in IO? Or is even crossing over like we've seen the heterogeneity of the curves like in surgical trials? Patients do very poorly from surgery, they do worse, but if we don't kill them, the first surgery, they do better. That was kind of dramatic, wasn't it? But we know, I mean, again, you have a bad surgical complication, you can't get the best therapies. I love surgery, I think it absolutely has a role, but when you look at those curves, the surgical curves usually are lower to begin with. When I talk about hazard ratios, how many of you can visualize a hazard ratio, right? Like, what does 0.35 relative risk reduction mean? I can visualize the curve. So for me, that's hard, but it's the most important, because we're looking at along the curve what the difference is, really showing you the improvements. Obviously, we always should present those with confidence intervals as well as the p-values. And it summarizes the entire curve. But really, what the curves look like tell the story, I think. So let's look at with recurrent disease. I put this slide up here to remind us that the drop-off rate is marked from line to line of therapy, especially in PROC. Now that could be changing because our therapies are better. So we'll have to look at this in real-world data going forward. And what's the classic trial? Aurelia. I was talking to Eric earlier today. It was great to revisit some of the original platinum resistant. This was the first trial that we were like, man, we can make a difference. And you see some separation of those curves on PFS at the end, but really they all come together, and we see that. And we're going to see that if we follow patients long enough in platinum-resistant disease. So when we're talking about, and Nicoletta, wonderful presentation, covered so much information. Where is this in context? Remember that Aurelia, we were excited about a combination response rate of 15-ish%, plus or minus. And the current response rates, if we take out weekly Taxol, like in Javelin, looked at PLD, 4%. 4%. CoRail, 12%. Ninja, 13%, which is the highest. It's really 5% plus or minus 5%. Mirasol, where we combined everything, looks more like Aurelia. So weekly paclitaxel, and the reason I'm harping on this, weekly taxanes are really clearly the best treatment for platinum-resistant ovarian cancer. Unbelievably consistent. You guys have heard me say this, 30% plus or minus 5%. Unbelievably consistent across all of these trials in contemporary patients from 1 to 4 prior therapies. Very consistent, 30%. So when putting this in context, we have to think about what is our standard of care arm and our comparison. So, antibody-drug conjugates have changed. Mirasol, not only did we see improvement, but survival improvement, progression-free and survival. But I've heard people all the time go, oh man, it's 1.6 months difference. No, that's the median. The hazard ratio is a 35% reduction. So look at where I've drawn the line. I've added that line right there in that month-and-a-half snapshot, that 50% of your patients. But clear separation of those curves, and you see drop off right away. Clearly differentiated improvements in the outcomes. Early and sustained separation and rapid disease control. So important in our platinum-resistant ovarian cancer patients. Again, seeing immediate. And then how about the tails? When we're looking at this, we're seeing that persistence over beyond a year. And why is that? Because we have more effective agents. 42% response rate in Mirasol. And did that translate? It translated to survival benefit. Not only do we see survival, this surprised us how quickly these curves separated, showing how sick our patients with platinum-resistant ovarian cancer are. Separation, if you don't get response, they progress, and many of them pass quickly. Again, hazard ratio, 0.67. In this case, the medians now have separated, so about 4 months difference, about just short of that. But really, those curves clearly show your patients are doing better. Now, Rosella. I've heard this over and over. It's 1 month difference, Dave. What's the big deal? No, it's a 30% reduction, and you have the best therapies, weekly taxanes, in your comparator arm. This isn't PLD and topo, single agent gem. I don't know how we came out with that one, but we did, right? Weekly taxanes. And the performance in that group was once again 30%. But clear separation, so it's really interesting because it's almost like an ADC effect with the relacorilant. So that mechanism of resistance, overcoming mechanism of resistance stories plays out. But when we see and look at this, tails, it stays separated. So you're seeing that benefit almost an immunogenic. And you heard Kat, I don't know if she said it pretty quickly, but we have this, the overcoming the immune suppression of cortisol. Okay, so you're blocking that. So you see those benefits. So this MOA, and I'm not an MOA, I'm not that smart, right? Just tell me if it works or not, and how my patients do it. But this MOA is so different, we spent some extra time on it. And it's really interesting we look at these results. And that translated to a trend right now. We're waiting for the final analysis on Rosella. And this landmark, the chance of being alive at a year, 50% versus 60%. Modest, but pretty good. Hazard ratio, once again, a 31% improvement. Now, I want to pay attention to the median follow-up here, 13.9 months. That's important because we put that in context of B96 at interim analysis number 1, about the same, few extra months. Again, when you're looking at your medians here, pretty modest, but you're 30% improvement. Utilizing Pembro with the best therapy. Nicola corrected me earlier. She said, no, Dave, not only did we have weekly taxane, we had plus or minus Bev. You're right, that is the best therapy we have, 54%. So I think when you look at that, it's so important to put in context both these trials. We had the best therapies in the comparator arm. This was not for underperformance of the control arms. This was, we have better agents working. But 13.9 months, 15.6, very similar with regards to that benefit. What's interesting here is then we look at IA2, 26.5 months now. 26.5 months. Now we're seeing those platinum-resistant curves come together. They're bananing a little. But it's important to remember, in platinum-resistant, we're not curing anybody. If you follow them long enough, they're going to come together. But we saw, again, that improvement in our hazard ratio just short of 30%. And here we see survival benefit. And these landmark numbers, I put into context for patients. 39% chance of being alive at a year and a half versus 51. 10% real difference, or you could say that's a 30% improvement hazard ratio, right? How about crossover? This is the thing we didn't talk about enough, and when Ahmed Oza presented this at ESMO a few years ago, Aerial 4, remember Aerial 4? Okay? We looked at platinum-resistant, platinum-sensitive, and fully platinum-sensitive drugs with PARP inhibitors. I've highlighted these 2 boxes here. Look in the far right. Highly platinum-sensitive, more than 12 months before they recurred on platinum. The patients who were on the chemotherapy arm versus the recapitulated chemotherapy, only 15% of patients 15% received subsequent therapy. Guys, those patients weren't cured. They went to hospice after this trial. Platinum-based therapy, the second lower, 10% in highly platinum-sensitive patients. So if you don't treat a patient and put them to hospice, they don't live as long. But in the recapitulative arm, half the patients, 46% to be exact, did not get therapy. And when we see this, we have separation here of the chemotherapy arm, and you see the difference. Let's spend just a few minutes on first line. Once again, our Bev-218 ICON 7, we see improvement of hazard ratio 0.62, but those curves come to banana curves, they come together. In the difference in first line versus recurrent setting, we really need to change that focus to, are we curing more patients with a number of therapies? ICON 7 high-risk population, clearly banana in the upper left there. So we're improving people, having them live longer in that context, but I look at this much differently. Are we curing more patients? People would say, you don't cure patients with advanced ovarian cancer. Really? We don't? That's 7 years of follow-up. If you haven't had a subsequent therapy there that long, you're cured. Look at how few events occur beyond 3 to 4 years. 45% of people never received a subsequent therapy versus 20. We went from curing 20% of patients with advanced ovarian cancer to 45 if they had a BRCA mutation. Now, could here the progression-free medians, the medians be overestimated because it's right at that 50th percent. So here, the appearance of the curves and a hazard ratio of 0.3, well, this was 0.37 on this subsequent, makes a difference. Ironically, overall survival still was not statistically significant. We say it is, but it wasn't. So we're missing the importance of the tails here. And the tails in first line therapy are curative intent. And we see that in the updates of PRIMA in the HRD population. Those curves stay separate. 16% very consistent in first line therapy, 15% patients who don't recur, plus or minus 5%. But now we had 35% in the HRD population. But at HRD test negative, or HRP labeled here, we had those patients come together. I don't think we're curing patients with HRD test negative with PARPs. So this is a curve I put together. If we're throwing 3, 4, 5 drugs at a patient, we need to see the curves separate and persist beyond those 3 to 4 years, because so few events occur that is really much more realistic curative intent. And what are some of the challenges we have yet still in overall survival? Because of the crossover, the post-progression survival, how long, right? Variables we don't even know how to measure. And then obviously, as we talked about Area 4, imbalances in subsequent therapies. There are different ways to look. Again, in my visual recollection, I picture those curves. But how do we say it in a simple way? Medians are terrible. We should stop using medians, all right? Landmark survival. What's the chance you're alive or disease-free at 2, 3, or 4 years? Because if you're disease-free at 4 years in the first line, you have a pretty darn good chance that that cancer is staying away. Restricted mean survival time. Debbie did a wonderful job at WAGO talking about some of the alternatives here and how important that is and how important we need to look at the contribution of each of those. But to me, just look at the curves, clear separation. I included this slide for completeness. I think it just kind of shows some of the different ways we can predict the probability of our curative intent. We don't have time to go into the details. So please remember, medians are just snapshots. Describing the curve, when we talk about hazard ratio, where does that curve look like? And are we seeing long tails, early separation? That's the real clinical behavior. If you watch a platinum-resistant patient long enough, they're going to recur. We're going to bring those curves together. So in that context, how they stay apart, how we get them to live longer to make it to those life events with a better quality of life. But yet in first-line therapy, we need to change the dialogue. We need to start talking about curative intent, and we need to work with our regulatory agencies about landmark studies, landmark time points, to show that beyond 4 years, the rate of events is quite low, less than 3 to 5% per year, and that, for us, is important. Appreciate your time. Happy to take any questions.
Thank you, Dr. O'Malley. Now I welcome all the faculty for panel discussion, treatment integration, and what's next. Okay, so I have prepared a few cases for my colleagues here to discuss, and hopefully it'll be a little controversial. So we have a 62-year-old with recurrent platinum-resistant ovarian cancer. At diagnosis, she received surgery, was a stage 2C, received carboplatin and paclitaxel for 6 cycles. 18 months later, she recurred as platinum-sensitive ovarian cancer with carcinomatosis. She received 6 cycles of carboplatin and an ADC that targeted FOLR with the topo-1 payload on a clinical trial, and then she received that ADC as maintenance. She progressed 4 months later after the last platinum. She was FOLR high, HER2 new 1+. Let's say all of these new regimens that we've discussed today are available. What would you recommend for the next line? Dr. Colombo?
So you said that she's folate receptor high, yes?
Correct.
And the ADC she received was, the payload was topo-1.
Correct.
Okay, okay. Yeah, of course, here we do have several options now that we described earlier. In this situation, probably I would consider to use an ADC because it is a different payload that we are using with mirvetuximab, so it could work. We don't know exactly, about the resistance to ADC. We still have to learn. But theoretically, being a different payload, it could make sense to try with the ADC because she has folate receptor alpha high, and so in this case, we know that this could be a good predictive biomarker for this patient.
And Dr. O'Malley?
I thought you were going to say weekly Taxol Pembro. I think as we look at this, the sequencing question obviously is unanswered. And for me, the payload is, in my mind, is probably more important than the target. So having that high folate expression and having the patient not have MIR with an anti-microtubule, I definitely would consider. We have survival advantage, but now we have survival advantage or almost survival advantage in 2 weekly taxanes. And to me, it's really forced me to rethink how I'm going to sequence these drugs. So many of my patients travel from more than 40 minutes away, often 2 to 4 hours away to come see me. So the weekly taxanes can be challenging. They all cause alopecia. We're always concerned about neuropathy. So I've always kind of pushed them back until what I say is I needed a win. Like when I need a win, I go to weekly taxanes. But is that the right thing? Should I be utilizing those patients earlier? We had a conversation yesterday, Nicoletta. B96 was only first or second line. We wanted to really have that bone marrow preserved. I mean, should we be going to a B96 regimen or a relacorilant regimen here? Because as I talked about, there is an immunogenic component to relacorilant, I believe.
Yeah, in fact, of course, the weekly paclitaxel is an option, and nab-paclitaxel for sure. My patients do not lose their hair because I use the cooling cap. So just to say that, it's not always the case that they have to lose their hair. So that's of course, but there is, as you said, many of your patients are coming from, far away, so to come every week maybe. On the other hand, I must say that the weekly regimen sometimes is kind of reassuring for patients. I mean, for my patients at least, because many of these patients with platinum-resistant recurrent ovarian cancer, they also may be symptomatic. And to come every week to the clinic, for them is also an opportunity to discuss their complaints, their, not feeling good, and to try to help them in some way, even with some palliative care. So I think there are pros and cons, depends on your population, of course, for sure. But I think, I mean, I don't know, I understand that it's different, the situation in the US and probably in Japan. I was discussing this morning with my friend from Japan, and also for them, weekly paclitaxel is not a regimen that they're using very often. For us, it's very common, actually. It's very popular, I would say, to use weekly paclitaxel. But I understand that there is a different culture also. Maybe in Japan, they also don't like to go every week to the clinic. The Italian patients, they love us, so they come very, you know, they love to come every week. So maybe it's different also from the culture point of view.
Well, the other thing that I think in the US we get a little spoiled because the label, that 1 to 3 priors for some of our novel agents, for most payers, doesn't really apply. So I can, even though the trial was done 1 to 3 priors, 1 to 2 priors, I usually can bring that in much later than that 1 to 3 priors for like MERV. When I talk to my European colleagues, like, no, we need to, many countries, you have to stick that 1 to 3 prior.
Yeah.
So that, it would influence my decision also, because I don't want to miss the opportunity for some agents.
Yeah, and if I may, just, we are discussing this 1 to 2 and 1 to 3 priors. I want just to stress that not necessarily only 2 prior is better than 3 prior, because in fact, in the B96 population, 35% of patients had primary platinum-resistant disease, which is much worse, as you know. So in other words, you know, you have 2 priors, but that means that you became resistant much earlier, and biologically, this is a worse disease compared to someone that become platinum resistant after 3 lines or so. So that's something that we have to keep in mind. And in fact, I mean, if we follow the rules of 2 prior, 3 priors, maybe in this case, to use the weekly regimen now, after 2 priors, and then save the folate receptor for later could be also another strategy, of course, to follow.
I think that's a really important point, Dr. Colombo, and I hope our industry colleagues heard that, because I think it's a problem that we restrict our trials to 1 to 3 priors. That's not the actual patients we're treating a lot of times in our clinic. And there's a big difference between somebody who gets 3 or 4 prior lines of platinum-based chemo versus somebody, as Dr. Colombo just said, who gets 1 line and is platinum resistant off the bat. And so a better way to think about it would be allowing up to 2 prior treatments in the platinum-resistant setting. So I'm just going to make that point. Okay, so we're going to move on to our next case. Thanks for that discussion. We have a 58-year-old who was diagnosed with stage 3C high-grade serous ovarian cancer. She underwent primary debulking surgery, followed by 6 cycles of carboplatin and paclitaxel. She is HRD positive, her tumor is. She's on olaparib maintenance and then recurs 22 months during her PARP maintenance. How would you treat this patient?
Yes, so that's the new category of patients that we you know, have to treat in our clinic, and these are what I call platinum sensitive but PARP resistant, because she progressed during PARP. And as we know from some retrospective studies, but it's something that we see, I think, every day in our clinic, when the patient progress on PARP inhibitor, they tend to be a little bit more resistant to subsequent platinum, even though formally they are platinum sensitive. But you know, this cutoff of the 6 months and so on is now different when the patient receives olaparib or niraparib or rucaparib or whatever PARP inhibitor, because we know that the response to subsequent platinum will be less and less. So right now, I treat these patients again with platinum, even though, you know, but as you know, there are several trials now planned in this specific population where we want to see whether the introduction of a different drug, such as, for instance, an ADC, can really, you know, lead to a better outcome, because we know that many of these patients will be resistant. But still, you have about 30% of patients that will respond to platinum, so I think it's worth it trying. But my choice would be to include this patient in a clinical trial if I have a clinical trial looking, of course, at a new drug, maybe together with bevacizumab compared to the classical platinum-based regimen and bevacizumab.
Yeah. I think, Ketta's presentation, that data was really nice to really, in my mind, justify using a non-platinum doublet in some of the trials which will be ongoing here, that are ongoing, and I suspect we'll see more of those in the future. So for me, obviously, that question will be important, particularly those who have progressed on PARP. Without that availability, I would also go back to a platinum doublet. And one thing we didn't talk about on the previous case is one of the best regimens for platinum-resistant disease is platinum. Particularly if somebody had a nice response and then progresses within 6 months. So in this case, I'd clearly go to platinum, probably with Bev, platinum doublet with Bev, and if there wasn't a clinical trial available.
Okay, so let's say she gets carboplatin, PLD, bevacizumab, and then bevacizumab maintenance. Her best response is stable disease, and she recurs 6 months after her last platinum. Now what?
Yeah, that's very nice because, again, I think we have to go back to the definition of platinum resistance, because formally 6 months, I mean, if it is less than 6 months, should be platinum resistant. But I think it's much more than just looking at the platinum-free interval. As you know, you have to look overall what's happened. And as David said, there are several patients that may still be very sensitive to platinum, even though formally, the platinum-free interval is less than 6 months. In this case, however, I'm looking also at the response to prior platinum, to the last platinum. So she was treated with carboplatin and PLD, and unfortunately, she only was stable. So
Correct.
There was not excellent response to platinum, as expected. We discussed earlier that these patients are less sensitive to platinum. So in this case, the patient did not respond extremely well to platinum. So even though it's kind of borderline in terms of 6 months, I would consider this patient more platinum resistant, okay? And then at this point, I would go probably for a regimen for platinum resistant. And here, of course, I would consider weekly taxane. And of course, you can decide whether to use if we have available, this is not available yet, of course, the combination with Pembro, but let's assume that will be available, and the same for relacorilant. So I think one of these two regimens should be chosen for these patients at this point. So basically, she's platinum resistant for me because she did not respond to platinum, and she recurred in between 6 months. And so I would go for a regimen with weekly taxane, probably. She was on bevacizumab. So, we may discuss Bev after Bev. This is a very nice topic. And as you know, we do have evidence that Bev after Bev is effective in platinum-sensitive recurrence because the Mito-Mango study showed that you can retreat patients with Bev and with similar results. In platinum-resistant, the first evidence that we have is really B96 because in our study, 50% of patients were previously treated with Bev, and 30% had Bev after Bev. So, and this is the first evidence that we have of the efficacy of Bev after Bev in the platinum-resistant population. And it is effective, in fact. So this one is progressing on bevacizumab. So, you may argue whether to continue. What would you do?
No, it's, this is what we see every day, right? I mean, these are the tough choices. Now, this lady was really symptomatic, weekly taxane. If she had, Deb did this great retrospective paper as a fellow showing that if they had a disease in their cul-de-sac on bimanual examination is one of the biggest predictors of BEV-associated bowel perforation. If I look at the CAT scan, she has disease all over her bowel, or if I do a bimanual and she has a bunch of disease in the cul-de-sac, I'm not going to do BEV, right? And so I think as we look at that, those are the questions that we have to ask and answer and try to predict. For me, weekly taxane here, if she was symptomatic, obviously clinical trial as we've discussed, and if she had disease on her bowel, I was worried about bowel perforation. If I had relacorilant, this would be really the perfect patient for till we have the data from Bella looking at it combined with BEV.
And I think that brings up another point about our eligibility for trials, because, when you force people to be, recurrent within 6 months of their last platinum, it doesn't take into account these things that we're discussing. So I think all of us agree on stage and probably out in the audience as well, that if somebody best response to their last platinum is stable disease, especially if they're on maintenance, it's hard to call that patient platinum sensitive and re-challenge them again with platinum before we can put them on a clinical trial. So these things are barriers, and these are patients, I pick these things on purpose because these are the patients that we have in clinic, and many times they're excluded because they don't meet these strict definitions, but it just doesn't make sense to put them back on platinum and force them to recur within 2 or 3 cycles and then put them on trial. All right, our last case, 67-year-old diagnosed with stage 4A high-grade serous ovarian cancer. She gets neoadjuvant chemotherapy for 3 cycles, an interval debulking to no gross residual, has 3 additional cycles of platinum-based chemotherapy, and bevacizumab is added to the last 2 cycles. She then goes on to receive bevacizumab maintenance. The tumor is homologous recombination proficient. She recurs 3 months after the last platinum dose. The FOLR is 45%. The HER2 neu is 1+. What regimen would you recommend for this patient? And would it be different if she had not received prior bevacizumab?
So I'll start with this one because this is the case that I talk about all the time, which is your patient comes in, her hair's just growing back. She's got about this much, right? And you go, okay, I got this great regimen for you. It's called taxane. And she's like, isn't that what I was just on? And this is really tough to go right back to weekly taxane in 3 months. It may be the right thing, but this is a tough one for me, particularly with the B96 data, and then at the relacorilant data where we included that 1 to 3 month group of patients. So, but that is hard with the patient sitting in front of you to say I'm going back to a taxane. Now, she has 45% in the US, NCCN guidelines with Merck-Bev, we could go down to as low as 25%. And I would consider it there. Obviously, a ADC clinical trial here, directed to the folate receptor would be my #1 choice. HER2 was 2+ or 1+? 1+. 1+, yeah, so that's a tough one. I'm not sure 1+ and 2+ is any different. NCCN differentiated, I'm not sure it's any different. But weekly taxanes would be tough here, and maybe I'm wrong, and in 10 years, I'll say that answer was stupid. I don't know, what do you guys think?
No, this is a typical patient where I would consider a clinical trial for sure. So my first choice will be to look for a clinical trials where, with the promising ADCs. We have a lot of these promising ADCs coming, you have seen, not only FR alpha, but many others. So for sure, this is the candidate for clinical trial. I would look for either phase 3 or even phase 1, if this is available for sure. Because otherwise, yes, this is a case where, 3 months, I would consider this definitely platinum resistant. She had neoadjuvant, I don't know why, but probably because, the tumor had a very bulky presentation. She was not inoperable, so it's prognostically a bad case. And despite BEV, she relapsed 3 months later. So she's definitely platinum resistant. So As you said, going back to weekly paclitaxel, yeah, the patients may complain and say, well, I just got this, platinum, and now you are giving me again the same. Even though I may explain that, the weekly regimen may be different, of course, we cannot give this patient mirvetuximab because in Europe we are kind of strict with the indication, so she's not eligible. So it's difficult, but I don't think I would give her PLD or topotecan for sure. That's something that we have been doing for so many years, but I feel it, almost immoral and unethical to propose the topotecan or PLD because we know the response rate is 10%. I mean, it's so low. And again, with weekly paclitaxel, weekly, even in the relacorilant trial, of course, you can get much higher response rate and greater benefit. So even though it can be difficult for the patient to go back to a weekly regimen, losing there in US, not in Europe, but not in Italy. But
well, yeah, can I change my answer? If I had only Doxil and Topo left, I'm going weekly taxane, hands down.
No, you are right. No, do you agree that, to use, still we are using PLD sometimes, but when we are desperate, when we don't have anything else, but otherwise, I don't think that's a good regimen for our patient.
Well, thank you all very much. I'd like to go ahead and open it up to the floor for our audience for any questions and answer session.
Okay, good. One here and one there. Yeah.
Excellent discussion and lecture on resistant cases of ovarian tumor. What is the treatment of platinum resistant with stage 4 bone metastasis of the ovarian tumor, which is very painful?
So you asked about the Aurelia trial?
How would it change with bone mets? How would it change if you had
You
bone
add
mets?
something along with the chemotherapy, like radionuclide therapy for bone pain palliation. What is your experience?
With bone mets?
Yeah.
Go ahead, Dr. O'Malley.
It's such a rare occurrence. I often, the first thing I do is pick up the phone and talk with my breast medical oncologist and make sure that I'm using the supportive care measures for bone mets. From an outcome standpoint and a treatment, there's not enough data to say we shouldn't do anything we'd always do. Following these lesions a little bit harder, and I also would definitely consider, depending on where the lesion is, some directed radiation to that area if they were symptomatic, or I also put my heads together with my ortho-oncologist and radiation oncologist to see if they think that'd be the right thing.
Okay. And one more question. In stage 4 cases, what is your recommendation in the diagnosis of these type of the cases? Which type of the modality can be used to diagnose serosal metastasis or brain or lung metastatic or lymph node metastasis? Which modality?
To diagnose, in general, I think at least in the US, we don't routinely scan people's brains with ovary cancer, but we routinely, usually follow with CT, chest, abdomen, and pelvis. There definitely are people that follow with PETs. I find that pretty expensive.
FDG PET-CT?
What's that?
PET-CT or PET-MR?
PET-CT. PET-MR is not widely available at even a lot of academic institutions in the United States. And then I think if somebody has a lot of chest burden of disease or has symptoms, that's when we scan the brain. And just to go back to your question about bone mets, while I agree it is uncommon, especially early on, you do sometimes see it. And I've certainly had this happen on a clinical trial where, a patient had imaging, there was nothing there, then you repeat the imaging, and there's something there. I usually don't call that progression. I just say that I think it's treated bone mets that we're now picking up because we weren't, CT may miss that. And so I usually just start a bisphosphonate and don't take a patient off trial solely for that, unless they were super symptomatic, had a pathologic fracture, something that's obvious.
Yeah. First of all, this is not very common. I'm wondering whether in your region is more common to see, metastatic disease in the bone. But usually, many of these lesions are quite asymptomatic, and the patients are doing very well. And my radiotherapy usually does not want to treat if they are asymptomatic. So you have to consider also, if is symptomatic or not. Otherwise, you may just follow them and then see when they become symptomatic, then or rapidly progressing, then you may consider this. But even it's more rare at the primary diagnosis. You are asking about a stage 4 with bone metastasis at the primary diagnosis. It's quite rare actually for me, at least in my region, in my country. Usually you may see metastatic disease in the bone, after 2, 3, 4 lines, or some of these patients, with a very long history. And even the brain, yes, the brain can occur, that's right, not typically at the first diagnosis, but particularly in patients. I had few patients on PARP inhibitors in remission, intraabdominally and so on, and they develop brain metastasis. This is something may happen, because I think you change a little bit the natural history of the disease, and sometimes you may have something like that. So yes, we don't check regularly the brain, I must say, but as Debra said, in case of very extensive disease in the lung, for sure, then it's better to check also the brain. Otherwise, we just go with the symptoms.
We have a question over here on the left.
Yeah, thank you so much for the nice overview. And I just wanted to ask, given to Dr. Nicoletta, that previously we've had so many negative trials in a similar situation for use of immunotherapy, even in the previous platinum-resistant setting. So what is it that made a difference in the B96? I mean, apart, of course, from the immunotherapy that we used, previous ones had.
That's a very nice, of course, that's the question. Even though usually we wonder why a trial is negative, not why it's positive, but in this case, it's the other way around. Well, I do believe that we believe that we choose particularly this regimen, which is a kind of metronomic administration of chemo, the weekly paclitaxel. Because there was evidence, even in, there was also a trial looking at the metronomic cyclophosphamide together with anti-PD-1 and bevacizumab, showing that there could be really a synergistic in this particular situation. And in fact, and so that's why we wanted to have only weekly paclitaxel together with Pembro and not other regimen, because we thought in this synergistic effect of metronomic chemo plus immunotherapy. And actually, if you look at the AGO study, which was similar to ours, but they had not only weekly paclitaxel, but they had also PLD and topotecan. They compare this regimen with atezolizumab. And if you look at the subgroup of patients receiving weekly paclitaxel, you see a very similar trend. But of course, there was no power to demonstrate a difference in this case. But it's really very, very similar, only for the population with weekly paclitaxel. So I think that's the main difference.
Thank you. And may I just also ask that if a patient is in the similar situation, ineligible for bevacizumab, meaning she had bowel obstruction, would you still go ahead and use weekly paclitaxel and pembrolizumab, that subgroup who did not, like 30% who did not receive bevacizumab?
Okay, so I do believe a lot in bevacizumab, and I use a lot of bevacizumab in front line and second line, but in our trial, if you look at the forest plot, the benefit of adding pembrolizumab to weekly paclitaxel was there regardless the use of bevacizumab. So even in the 30% of patients who did not receive bevacizumab, you see a benefit with the addition of pembrolizumab also in this population. So I think, yes, if the patient is not eligible for bevacizumab because of a contraindication or the risk of bowel perforation and so on, we do believe that the addition of Pembro to weekly paclitaxel may provide a benefit even in this case. At least looking at the forest plot, you can see that. Yeah.
Thank you. Any other questions? All right, I'm going to ask 2 more questions of my colleagues, and then we'll wrap up. So, for Dr. Colombo, does the CPS score matter for weekly paclitaxel, pembrolizumab with or without bevacizumab?
The CPS, so you are asking about the CPS?
Yeah.
Okay, so yeah, we designed, since, we know that it could be a predictive biomarker, even though it's a kind of very, as I say, imperfect, test, because it's really not so precise, so it's difficult. And we found a much higher positivity than expected. When we designed the trial, our assumption was 50% of patients positive for CPS, and we found 72%. So it was really much, much higher. So basically, the majority of our patients had a CPS 1 and higher. And so, but as you have seen, yes, you see the benefit in the CPS 1 and higher, but also in the intention to treat population. I don't know if this is because the majority of patients were anyhow, CPS 1 positive. And even in overall survival, we presented the data for the CPS 1 and higher, but then there has been a press release saying that the benefit is also seen in the intention to treat population, even though probably the magnitude of benefit is less. Now, I don't know what the authorities will decide about the potential approval of the drug, if they will go for CPS or not, we will see. But I think the benefit is seen also in the intention to treat population. Probably the magnitude of the benefit is greater in the CPS 1 and higher population.
Thank you. All right, so Dr. O'Malley, how will you choose which Fuller ADC to use if multiple are approved?
I mean, the data, not just efficacy, but safety as well as the schedule. So most of the agents right now being developed are every 3-week regimen for the folate receptor target agent. So that the regimen will, if they're all every 3 weeks and they're all IV, that would be not a differentiator. But when you look at the toxicity and you're looking at the efficacy, that will be the question for sequencing, as well as our familiarity. I had the luxury of participating in the first in-human MERV trial. I'm very familiar with MERV. I've been working with it for now 11 years. But yet I've also had the opportunity to participate in almost, now, all the other folate receptor topo-1 payloads. And so I think as you see that and get that, and that's the advantage of having early phase trials, there may be some differentiation in the toxicity, and it will come down to experience as well as what the data shows on toxicity as well as efficacy.
Thank you both very much. So we're going to wrap up now. Basically, what I would like to say in closing is we now look like we have 3 regimens with overall survival benefit. We know we have mirvetuximab, we have the B96 regimen of weekly paclitaxel, pembrolizumab with or without bevacizumab, and likely also nab-paclitaxel with relacorilant if their mature OS holds true, which it looks pretty promising if you look at the curves. It looks pretty similar to these other drugs that, Dr. O'Malley kind of showed us that data from the B96, also Dr. Colombo. And it's also pretty similar to what we saw with mirvetuximab in the confirmatory forward trial. So I think that's really exciting because we didn't have that a couple of years ago. So we are making progress, but I want to kind of hone in on what Dr. O'Malley said, that we now really have to start thinking about how do we cure more of these patients. Like, for a while now, we have been kicking the can down the road. We are helping our patients live longer and hopefully better. But the goal is to cure these women, and how do we do that? So we are going to be moving up some of these drugs, no doubt, to earlier lines. There are many antibody-drug conjugates under development. I think Dr. Colombo did a nice job kind of showing us, and you see how many have the same target, and then we also have some novel targets that are coming. But the bottom line is we have two real payloads, right? We have a microtubule toxin and we have topo-1 payloads. There are so many unanswered questions. How are we going to sequence these ADCs? What is the appropriate sequence? How do we decide? What if some of these antibody-drug conjugates don't need a predictive biomarker? How does that kind of fit in? So the more that we're doing this, the more unanswered questions that we have, and how are we going to decide which one to use? Because if you only get one shot at a topo-1 payload and one at a microtubule, then how do you decide which ones to do and what order to give it in? And finally, we obviously need novel agents, and we saw some of those. We went over some mechanisms of action by Dr. LaRusso, and then Dr. Colombo also showed us some different things besides ADCs, like bispecifics. And we're gonna have to get comfortable with cytokine release syndrome, or you're gonna have to get friends in your institution that are used to this, whether that's a medical oncology colleague or cellular therapy colleague. And then there are also these cell cycle inhibitors, for example, CDK2s. So there are many other drugs under development, and while their response rates may not be hitting those, what we're seeing, say, with some of these novel things with either a taxane combo or ADCs, we're going to need something after those drugs. And so 30% is nothing to shy away from when we're talking about like Doxil and gemcitabine and topotecan, which at best have a 13% response rate. So I thank you all so much for your attention and for my esteemed colleagues in joining me here today, and hope you all have safe travels home.